Good afternoon, colleagues. I have totally had a very long introduction, and apologies for that. My name is Okwalinga. That's the correct one. And I work as a biosafety biosecurity advisor for the Department of National Health Laboratory and Diagnostic Services, NHLPS. I also work for JCRC. So I work in two places. I'm the only person who is allowed to work in two places at the same time. Okay. That's my name. I already talked about it, and I'm going to be talking the Ugandan situation, biosafety, biosecurity. And just to introduce, Uganda is one of the countries that is signatory to IHR, and so Uganda has a component on global health security. That is the global health security agenda, and under one of the action packages on prevent action package 3, that's where biosafety biosecurity is, and we will be discussing a lot of these components today in this meeting. So it's key to note that in 2015, after we had a lot of disease outbreaks, the emerging and re-emerging diseases. We had, of course, internationally we had the IHR coming, and so we have, just give me a second. Most importantly, I want us to note that the increasing threats and hazards from biological agents and toxins that we work with every day, from emerging and re-emerging infectious diseases, have become a global concern. And that's for sure. That's a very clear message for all of us. And this has demanded an increase in biosecurity. And that's why even being here asked that we increase our vigilance as we spend our time here. And so Uganda is implementing the Biorisk management under the One Health approach that is multi-sectoral, not only human health, but also across the animal health, the plant health, water and environment sector. So that is very critical to note. I already talked about this and I will not repeat. However, after that technical committee did that country assessment, we had the JEE assessment, the Joint External Evaluation by the WHO to assess our core competencies again on biosafety, biosecurity, and critically to note, in 2017 we had a few interventions put in place and started a work on our journey on biosafety, biosecurity around 2015, where we had that environmental assessment, and you can see that we now scored 3 in the whole of government evaluation, and then another 3 on our biosafety and biosecurity training and practices. And this to WHO is developed capacity, and I thought this was a very good step for us in a short time. So also in response to those gaps that were identified, the Ministry of Health, through the Department of National Health Laboratory and Diagnostic Services, working with these other MPS that you can see there, we have ministry, like I talked about, Ministry of Agriculture, Animal Industries and Fisheries. We have Ministry of Defense, which is very key in biosecurity. When we had the COVID outbreak, you realize that it was the Ministry of Defense that took over. It wasn't the Ministry of Health alone. So we have Ministry of Defense in our implementation. We have Ministry of Water and Environment. I've already talked about this. Wildlife is critical, and so the primary focus of the National Biosafety Biosecurity Coordination Office has been capacity development in terms of. So we are trying to look at competence in BRM, and and also compliance. That's what our focus has basically been. Just a walk into our journey from about 2015, we have had key milestones as a country. So one of the things we have had is a national biosafety manual developed for the human health laboratories in 2015. And then we developed our first training curriculum in 2016 for biosecurity training. In 2017, after realization of the need to continuously assess biosecurity implementation, we had developed a first quantitative assessment checklist based on the ISO standard 15190-2003 version. And so in 2017, we had our first quantitative PRM assessment checklist developed and then conducted. Subsequently conducted an assessment that I will be sharing the results as well shortly. And then in 2018, we had the second nationwide PRM assessment conducted again across the country. And then in 2019, we had the TOT for PRM under the One Health platform. So we incorporated now the other sectors. From 2018, we started moving towards the One Health implementation. So in 2019. So in 2020, we initiated the review of the PRM training curriculum to align the risk-based approach. 2020, there were key things that came up. Of course, COVID also came in, but also importantly, the WHO released the fourth edition of the biosafety manual, which was giving guidance on implementation of biosecurity, which is risk-based. And then also ISO released standards for biorisk management 35001. And then there was also a biosecurity ISO 15190 for safety in medical laboratories. And this was also revised from the 2003 version to 2020 version, which is the latest. Now, all these standards I've talked about are risk-based standards. And so there was a need for us as a country to as well realign our standards, our implementation documents to the risk-based standard. And so it's only in this year that we have aligned all our checklists and all our training materials as I speak today. And so all of them are aligned to risk-based thinking as per the standards that have just come. And so we have conducted our first assessment that we shall be sharing results with the team here in the house today. So that is our journey that we talked about. And also just to note, I will talk about the last part of this because I have made mention about we have a training program as a country on biosecurity that targets three tracks. Track 1 targets the non-laboratory personnel. Those like the nurses, the support staff, whatsoever, like it has been tailored to meet the requirements of those who may not understand very hard things. And then the technical track that targets the laboratory team, where we speak very difficult language, biosecurity, where we talk about pathogens and their containment. So those who understand the language, we train them on track 2. And then track 3 was designed for managers, where money is released, because we believe this is one of the places that is actually making our implementation not move smoothly. So we target them and tell them the importance of these interventions on biosecurity, and then they are able to release the money. So we have those 3 training tracks as a country, and we are proud to talk about this. So now that we have new standards, the new horizon, what does that mean? Of course, I've talked about the ISO 35001, and I've talked about all these standards. So allow me to go to the next. And I've also said that we have reviewed all our training materials to align to these requirements. And maybe most importantly, we we have, I'll talk about the last one, which I have not talked about. We have also developed a national PRM mentorship toolkit that is aligned to the two standards and the WHO biosafety manual for the edition, risk-based, like I said. And so this toolkit provides us a systematic way of conducting, of building capacity of our personnel in the facilities. So that is the other addition. So let's talk about the 2022 audit, and I'll just introduce it. This is the overall score, the score sheet. This is how it looks like. That's how we have grouped our scores. We have said that if a facility scores less than 30% in our assessment checklist, that facility is a very high-risk facility. It's a very high-risk environment. There's no safety, there's no security. There's no safety of persons working. There's no security of our agents that we are working with. So that's a high-risk facility, very high-risk facility. Those facilities that score 31 to 49, we have grouped it as a high risk. And these two, we have termed them unacceptable risks. And you wouldn't want to come from one of those facilities where you are either put at very high risk and there's no security of our agents that we are working with. So you would want to be in this category, which is acceptable risk. So 50 to 59 is a moderate risk. And then we have 60 to 79, which is the low risk. And then the very low risk, which is facilities which have scored greater than 80%. We consider those to be very low risk facilities. And a place that is good enough for working, meaning that systems are built, personnel are trained, personnel are reliable, they can handle all sorts of these agents, including those of high-interest organisms, so they can work in these facilities. Now, just a snapshot of our performance. Interesting to note, in 2017, like I said, this is overall performance across all the assessed areas. Key to note is that in 2017, when we started our journey, we scored at 33%. When we do overall the average across all facilities in the country. And then in 2018, we made good progress because we had a couple of interventions. Made good progress, we moved to 45. However, in 2022, we witnessed a drop in performance, and I can assure you this drop was attributed to the new requirements. Like I said, we changed all our training tools, all our assessment tools in line with the requirements, the risk-based thinking, which is now the idea that all standards that are being released are risk-based standards. So you'll not crucify us for that drop in performance, but it was it's critical to note that it dropped, and so we are moving, we have put systems in place to make sure that we move forward systematically. Just again to share, this is how we grouped our, when you see, I say green means anything above 80, and none of the facilities were assessed got in that score. And only 3 facilities managed to get in the low risk area, which was good, and with an average of about 66%. And then moderate risk, we had about 4 facilities. Now you can see where the majority of the facilities are. They are in high risk and very high risk, an area that we say we do not want facilities to be in. And so there's a lot of work to do with that, but like I said, we have put systems in place to improve this. If you have this conference next year, we will present this very thing, this very abstract, and want to see progress going forward. And of course, again, just to note, this was a summary of level of facility. We had national referral facilities, we had up to the lowest level. So, but just note as a summary that all of them, none of them, all of them were in unacceptable risk area. That is just key to note, summarize this slide. Looking at the average PRA performance across human and animal health laboratories, I told you we implemented One Health PRA system. So the animal health labs scored an average of 19.4, and the human health labs scored an average of 30%. And either way you want to look at it, all of them are what? Very high risk, isn't it? Either way you want to look at it. So there's a lot to learn and to do. I don't know whether the last persons can see this, but this was only trying to summarize the entire sections that were assessed. This is the entire scope that we assessed, but we're also looking at average across all facilities for each of the components that were assessed. So to say that the worst performance, the worst performed section was performance evaluation and continuous improvement. The current biorisk management system, as guided by ISO 35001, requires continual improvement. It's a requirement. And so you realize that facilities were implemented previously biosecurity, not in the concept of continual improvement, where you proactively identify opportunities for improvement. People were waiting for you to identify for them opportunities for improvement, but the system now requires that we have a proactive way of. So that was the worst done, followed by management support, management requirement. That was the other. Management is not support. When I talk about management, you know what I'm talking about. Management and support by security. And we have targeted this particular area for improvement. And of course, the rest, as you can see them. But most importantly, I'll talk about biosecurity, which is very critical. That the other worst performing area was biosecurity. And in the era that we are of emerging and re-emerging disease conditions, we cannot afford to have biosecurity perform that way, because we will have our agents misused. So we want biosecurity to probably be the one with the longest path, but not today. So it's something that we are now focusing on as a country to improve urgently. And then we also looked at ownership of facilities. We have private facilities, private-owned facilities, and then we have government facilities. Key to note that the average performance for government facilities was 28.8, which is still, of course, very, very low. And then the other one was for private facilities, we had a performance of 42.2, which was better. It was better, but still not where we want it to be. So it's critical to note that all of us have worked, but at least it looks like this management support at the private facilities. Maybe you want to clap for yourself, those who come from the private sector. For those of us who come from government, who have worked. We also had the uniform facilities, those military facilities. These are those that are for wananchi like me. Those of you who go to civilian facilities. We also made comparison of performance. And key to note again is that the uniform facilities performed better at 6.7 than the other facilities, the non-uniform. That is also an indicator that we are still trying to investigate. Is it because there is an order? When they say do this in army, you do it, isn't it? So maybe it's a good practice we want to borrow for this one HE. It's also something we want to look at. Most importantly, I think this is one of my very last slides. performance of facilities on establishment of functional occupational safety and health programs. This is where you, the workers, would be interested in. Because your safety, your security is assured. When you get an accident at work, this is your area of interest. But keep note that we had 56% had established occupational safety and health program, which is a good thing. But again, there's 3% that had not established occupational health and safety programs. And then we had those who are partially established. They are there. They're just there. Program is there, written, but they are not implementing it. They say we shall buy for UPPE, and they are not buying for UPPE. Probably those are the ones at the 11%. But the good thing about it is that majority of the sites had established this occupational safety and health program, which is a plus for the country. And again, this slide just tries to make a comparison from the last documented audit we had before there was a switch to the new risk-based ISOs. We picked about 10 areas of interest, very important areas. And the areas that we picked are continuous improvement, documentation, infectious materials and safety, waste management, health and safety of staff, personnel protection, laboratory security, laboratory premises and physical security, and then management requirements. Now keep in note that when we changed all our audit tools, all our materials, there was only one area which had a positive change, irrespective of whatever, whether the tools, the new one. There was only one area which was personnel protection. And this we probably want to attribute it to what COVID taught us. At least it was a plus in the entire assessment. So in conclusion, therefore, we are saying that BRM system performance across the human and animal health laboratories is below average, following that realignment to those standards. And we are saying management support and buy-in is critical if we are to improve biosecurity in this country. Because that's where the decisions are made, that's where money is given out. So we need management support. So we are twisting all our implementation to make sure that we get managers trained on biosecurity so that they appreciate the need to inject finances in those places. So BRM capacity building, specifically mentorship, is one thing we are promoting. Now we didn't have mentors for biosecurity, and we discovered we were only providing training for years. But the trainings, so you train people, they come in a class, you train them, you expect them to go and implement, you don't get anything. If you get like a 5% increment from those who are self-motivated like me, then you are really basically doing nothing. So we have decided as a country that we need to introduce a mentorship, the mentorship arm, and we have trained mentors in line with these requirements. And so going forward, we shall be using all the three approaches of training, mentorship, and audit as the way of improving biosecurity in this country. Allow me to acknowledge the Ministry of Health in this work, CDC that funded this audit, and then JCRC funded by CDC, where this project for strengthening laboratory systems in Uganda 6, and then Biolabs REDS, our quality management systems partner, and APHL responsible for our informatics. Thank you so much.
Thank you very much, presenters, and the call. Actually, I was very, very attentive during both presentations because I really have interest in safety and security. From both the presenters, I really got worried I realized that really most of the labs assessed here were private, and the findings, ideally, and the conclusion that I made was it seems most of the labs in Uganda are high-risk laboratories. From the PSS opening remarks, she talked of us building resilient, efficient, and sustainable systems, and looking at the outbreaks we are getting, and the state of our labs. What are we going to do, or what have we picked from this presentation that we are going to do to sustain the efforts? It's as if we are going to go back to 2015, because there was some contradiction. Paul presented good progress concerning, I think, where we were scoring 1 and where we scored 3. But Diana said last year that we are high-risk labs, so it seems we are going behind. So are we going to sustain that? Thank you.
Thank you, Diana, and Paul, my brother from another mother. I was very passionate and listened keenly. My name is Paul from Kampala. I wanted to know, I've checked on the scores that Uganda we are doing bad. So my question is, what is Uganda as a country doing so that we can improve on our scores in DRM? And then I see that the facilities that you assessed, there were, if I'm not mistaken, either 52 or 44. How did you select those facilities? And on a lighter note, as my neighbor said, I've seen most people shaking their heads in the amusement. So how does one join, or if they're interested in the biosafety and biosecurity, how do they join you and handle the manpower? Thank you.
Thank you, Paul. Any other question?
Thanks, Jerome. My name is Patrick Sakibu. I work with the Uganda Blood Transfusions. But I'm here in the capacity of the Secretary to the Uganda Medical Laboratories Association. Good morning, ladies and gentlemen, colleagues in the fraternity. Good afternoon. I want to take this opportunity to thank my brother Paul Okwalinga and Diana for the presentation. I realize Biorisk safety is a key component of quality laboratory services in the country. I have a few concerns. One would be going to Paul, the other one going to Diana. Way back, I think before 2016, there was a comprehensive approach of trainings all over the country. And I think the trainings will expire after a period of time. Probably the certification you get will last for not more than 3 years. I would want to raise a question to Paul. What approach is being undertaken to ensure that this is revived to comprehensively see that professionals get this training? To make reference to Kenya, for example, Kenya has undertaken biorisk management as a major component. And as we speak, they have training programs. We have lab professionals training as biorisk officers, and it's really a key component, as you see. And the reason they undertook this was simply because there was a major gap among the lab professionals, and they want to assert that the House agrees with me, colleagues who have undergone training in the lab sector, that biorisk and biosafety is a component that is not seriously undertaken in the training. So I want to raise a question to my brother Paul, now that we have a very vibrant office and headed by you, if there is an approach that you're undertaking to ensure that professionals are able empowered in this. And of course, I want to thank you that you stated that you will undertake a comprehensive approach, or you assessed both private sector and government sector. I want to raise another concern in there, that how are you going to employ the private sector deeply in this activity, not forgetting the small-scale laboratories that we know contribute greatly to the healthcare service delivery. Last for you, Paul, is yes, we have got, I think, if anything, over 20 accredited labs in Uganda under government. And in your assessment, what were the key gaps that you found if these labs were part of the assessment, and yet we have them accredited in this aspect, of course, biorisk management inclusive. The other one goes to Diana. Diana, in your presentation, you talked of certainly the labs that were included in the findings that you undertook, and you say you selected 11 facilities. Like one of the colleagues stated, we saw that a number of the labs that you put across were private labs. What was the challenge that made you not consider government labs, majorly those that were accredited? And yet we know, in a way, besides just the testings that are done, the PCR based, we have got these labs are collecting samples in line with COVID-19. And lastly, you talked of one of the key challenges you found was the structures in these laboratories. What exactly do you refer to the structures in those laboratories being a major challenge for this? Otherwise, I want to thank the organizer, Leonard, the CEO of this arrangement. It's a very, very prudent session, and I want to encourage that subsequently we build this forth to strengthen the quality of laboratory service delivery in the country. And as I wind up, just to remind us that there will be a conference for the latter in November, 3rd to 5th in Okwalinga Hotel. And I want to encourage my brother Paul to bring up this paper and present to the professionals during the conference. This is a key component that we've seen year in, year out, not considered seriously. Thank you very much, ladies and gentlemen, for now.
I think there was a question over there. I don't know if it still stands.
My name is Martha Akia. I'm with the AAR as a laboratory technologist. So my concern to heal my question is Paul. Paul, the presentation has been very welcome. Unfortunately, I'm very worried with the applications with decipher, because if we are having biosafety and biosecurity going below the year you started, then this is very worrying, especially concerned about OSH, occupational safety and health. Clearly, say almost all the labs are in the high risk zone, generally. So I'm concerned. You said there was no OSH program at 33%. Enforced. Partially established was 11%, and established programs at 56%. Paul, this is putting us at roughly just above average in occupational safety and health. As a lab team who is dealing with Ebola right now, we've had COVID. I'm assuming at JCRC, you said it partially worked. I remember correctly. I am assuming that this is something that is very important, and I want to inquire, is this together with the government, was a specific entity that came to train you on occupational safety. And as a lab personnel, I got training, and I have measures that have been put in place at my workplace. So you concluded that 56% established a program. What I want to find out from you is the 56% that you initiated, what have you put in place to get compliance? Because it could be paperwork as well. So it would be on OSH where we are aware of what OSH is and what the paperwork is, but literally now that is reflecting in every report of this one that we have OSH and say initiated 56, we have most of the labs at high risk. So Paul, what is the way forward? Especially for both the private, I'm happy this time to see private and public included. So this is a general marker. As Paul, as head of Biorisk, management and safety, how does this report, how do you get it done? I want to know what is the way forward and what is the recommendation? And is it something we can take? Thank you.
Thank you very much. I think we'll have one last question.
Thank you, Mr. Jacob. Emmanuel Sambora, acting Biosafety Officer at Nabasio Hospital. I'm standing to appreciate the presentation by our team, Mr. Paul and Atwine. Just with our inquiry, there could be some activities going on by some of us being in private sometimes. We can wonder that they are there and we really don't know. My inquiry was, since this competence was done way back to 2016, and this is 2022, we wonder whether there are those other trainings that we should be, some of us that we are in the facility, we are biosafety officers, but this is now the conference of advantage that we should be now alerted whether those trainings are there, and moreover, whenever we try, we believe we can be fruitful to the companies we are working with. So if they are there, you can remind us, and we are updated. Thank you so much.
3 pages, but I will really try to summarize it in half a page. So, most importantly, thank you very much for the good questions. Again, these are programmatic questions, and I'll just give a few highlights. The first question was about whether there was confusion between the JEE examination, evaluation, the joint external evaluation, and then the assessment that we were presenting. In the joint external evaluation, where we are looking at WHO in response to the requirements of IHR, global health security, there are key components that they evaluate each country. So this is the country evaluation, where they come at highest level. They don't even get the facilities. They will come at the highest level and ask, we have a training program, we have this, and we have that as a country. We have most of the structures as a country. So we pass. And we got developed capacity as a country. Now, the assessment I presented afterwards is your assessment at site level. And the assessment at site level goes beyond just looking at the cosmetic things, but gets into asking you the occupational health and safety program. Like somebody has put it clearly, the paperwork, for example, you have an SOP that you have developed, you have a policy on occupational health and safety. You actually follow what you have said in that policy. You do medical surveillance. You have a program where you compensate workers. So when we get there, it gets that, isn't it? And that is where the trouble is. And that's why you see the difference in the scores. So I want us to separate the two assessments. JPD is a country assessment. The other is a facility level assessment. I hope that is clear. So what is Uganda doing has been a question almost from everybody. We have a roadmap, maybe just to let you know, one of the gaps we have as a country is that we have no regulatory framework for biosafety, biosecurity, which is a requirement for us to move forward, even for funds to be allocated. We don't have an act of parliament or a bill, whatever it is. We do not have a legal framework for biosafety, biosecurity implementation in this country. However, it is something in process. There are meetings almost every week where we are doing a regulatory impact assessment designed for biosafety, biosecurity. And so there's light at the end of the tunnel that probably in the next 1 year or so, we should be having maybe a bill or an act of parliament that allows us and gives us a very clear playground where we can implement this program. So it's something that is very big. But from our own level, as the center, CPHL, we are doing quite a lot as the National Coordination Office. We are systematically building capacity of trainers in line with the requirements of the standard. We have, like I said, introduced auditors. We train auditors for this program. We have trained mentors for this program. And so we want to approach it from all these arms and make sure that capacity, at least the paperwork, is in place. Because if I can tell you that most of the scores, managerial, for those of you who know the ISO standards, the managerial component was poorly scored. Actually, when you get many of the facilities, you get 0% in many of the facilities. And that is normally where you start the program from. You start from documenting what you want to do. Now, if you have not documented what you want to do, then you cannot implement what you have not documented. So that is actually one of the biggest things which is missing. So we have trained members who are really well trained to be able to support the facilities, to build these programs. But also, on the other hand, for the IPs that are in the house, we have a very deliberate plan. And also those who are from the regional referral hospitals and our regionalization program. We have very deliberate biosafety, security activities in those plans. And so, as I speak right now, we are pushing every day for people to implement these activities. What happens to the private sector is still a question. I'm also still guessing. The answer is out there for you to guess. But what I can say is that we have programs in place. We have a training program. There are private facilities that have contacted the center for technical expertise. And they facilitate the teams, and then we provide the training, we provide mentorship, and even audits where they need. And this is what we are doing as a center. For those in private, maybe you didn't know where to go, but now you know where to go. We will provide you with this capacity. For those who want to join the professional body of biosafety, biosecurity, there is hope. One, we have privately International Federation of Biosafety Associations, IFBA, that certifies biosafety, biosecurity professionals. They have about 4 certification requirements. One is in biorisk management, the other is in risk assessment, another is in waste management, and another is on biosafety cabinets. So if you want to undertake any of those, we can also support you to connect you to IFBA for those in country. But also the good news is that CDC Africa is working to establish regional centers of excellence that are an equivalent of IFBA certification, where members can apply to go to the regional center of excellence to be trained, and then they get certified as biosafety, biosecurity experts in the African component. And then the other thing I wanted what are we doing with the capacity building again is that we have currently as a requirement we are incorporating biosafety biosecurity in the pre-service training curriculum. Those who are in universities, those who are in medical training schools, it's now a requirement that they need to have a course on biosafety biosecurity, and we are currently working on this to incorporate biosafety biosecurity in the pre-service curriculum. For those in service, I have already talked about it because that has been most of what I have explained. What is the performance of the accredited labs? I didn't want to present that. It was one of my slides. But just to tell you, if I am looking at a biosecurity program, comprehensive, they performed at less than 40%. Comprehensive biosecurity program, in line with the requirements of ISO 35001 and 151A. I think that is the score that we have. I think it's about 44% accredited sites. You are accredited to 15189, but you are not meeting the requirements for safety and security, which are now very tight. Again, I want to emphasize, they are very tight requirements. They are risk-based. That for whatever you do in the laboratory, you must conduct a risk assessment, identify the pitfalls ahead of time, set preventive measures, and track them. Make sure that these risks do not happen. That's what the standards now require. And this is not what is happening. And that's why the performance of about 43% is. So, ladies and gentlemen, allow me, I hope I have answered all the questions. Again, if I have missed any, please reach me at lunchtime. We can talk. There was a question on occupation, Diana is reminding me, but I think I talked about it. Occupational health and safety is one of those that is actually would be a comfort for anybody who is in employment, that you want a system in place where you are sure that even when you get an accident at work, you are covered. You want to be sure that there are programs in place to take care of you and your family or whatever it is. But this for those who have documented, like somebody clearly said, they have documented systems, but many of them do not have the actual practice. So maybe that's what I can say for now. Over to Diana for the other part. We can catch up over lunch if there are further questions, and we can support.